Imagine suffering from severe physical pain every time you sit down, like for 10 straight years after having a baby. And then imagine curing that decade-old scar in just a few weeks.
Yeah, using nothing but a spun-down vial of your own blood, right? It sounds completely like science fiction, or maybe, I don't know, a really aggressive marketing pitch.
Exactly. But it's actually where regenerative medicine is intersecting with postpartum care. And that's exactly why we're doing today's deep dive for you, the listener. We are looking into a highly requested topic. Can the O-Shot, which is vaginal platelet-rich plasma, or PRP, actually help accelerate and improve recovery after childbirth?
Right, because traditionally this space has offered very few solutions for those chronic, lingering physical traumas.
Hmm.
So to get to the bottom of this, we pulled together a really fascinating stack of sources.
Yeah, we've got a great mix. There are clinical guidelines like the NHS-GP 6 to 8 week postnatal consultation guide. We're looking at randomized controlled trials, scoping reviews from medical journals, and even like detailed clinical protocols from different women's health practices.
It's a dense stack of data, for sure. But our mission today is to cut right through the noise. Postpartum recovery is, well, it's historically under-discussed. And while the O-Shot has gained fame almost exclusively for, intimate rejuvenation, we want to strip away the marketing.
Right, we want to see what the hard clinical science says about its actual ability to heal the physical traumas of childbirth. Okay, let's unpack this by establishing the biological baseline. Like, what exactly are the O-Shot and PRP?
Sure, so we all know platelets are involved in clotting blood, right? But the sources highlight that their real regenerative power lies in something called alpha granules. That's the engine of the whole process.
Wait, alpha granules? What
Yeah.
do those do?
Well, when a clinician takes a small sample of the patient's blood, they spin it in a centrifuge. This separates the red blood cells from the plasma, and that leaves you with plasma that is just densely packed with platelets.
Okay, so you're just isolating the platelets?
Exactly. And when those platelets are activated, their alpha granules release highly concentrated growth factors. We're talking specifically about platelet-derived growth factor, or PDGF, and vascular endothelial growth factor, VEGF.
So rather than just like patching a wound, those growth factors are essentially biological messengers, right? They orchestrate tissue regeneration.
Yeah, they kickstart collagen synthesis and promote angiogenesis.
Angiogenesis being the formation of entirely new blood vessels.
Right. And the O-Shot is simply the trademark protocol of injecting this PRP into very specific areas of the vaginal and clitoral anatomy.
Okay, but before we understand how the O-Shot fixes these issues, we need to look at what women are actually facing during recovery. Because, traditional care sometimes falls really short.
Absolutely. If you look at the NHS GP 6 to 8 week postnatal consultation guide, it's very telling. It explicitly instructs doctors to ask specific pelvic health questions.
Right, they're screening for urinary leakage, loss of bowel control, vaginal heaviness or dragging sensations, and sexual discomfort.
Yeah, and the fact that these questions are codified into national health guidelines, well, it validates just how widespread these structural changes are. Pregnancy and delivery cause profound physical alterations.
Oh, for sure. The sources document significant vaginal laxity and severe tissue dryness, which, by the way, gets heavily exacerbated if you're breastfeeding, not to mention episiotomy scars and stress urinary incontinence.
Exactly. And standard care usually defaults to prescribing pelvic floor physical therapy or maybe localized estrogen creams, which are, largely just management strategies.
Right, physical therapy strengthens the muscle and estrogen helps the surface level tissue. But PRP offers a fundamentally different pathway, doesn't it?
It does. By injecting those concentrated growth factors directly into the affected tissues, like the anterior vaginal wall and the clitoral area, you introduce a biological catalyst. It structurally rebuilds the damaged extracellular matrix.
It's like recycling your own body's elite repair crew from the general bloodstream, concentrating their numbers, and airdropping them directly into a disaster zone where the local cellular workers are just totally overwhelmed.
That is a great way to visualize it.
But I do want to push back on the core premise for a second. If the body already knows how to heal itself after birth, women have been giving birth for millennia. Why do we need to manually extract and re-inject the blood to make it happen?
That's a fair question. The body does send a repair crew, but the natural healing response has evolutionary limits, especially with severe tissue trauma, like a deep tear or an episiotomy.
Meaning it just sort of patches it up quickly?
Right. Evolution prioritizes survival over perfect tissue function. The immediate goal is just to close the wound fast to prevent a lethal infection. And that emergency response typically results in thick, rigid, inflexible skin tissue.
Ah, I see. It's prioritizing speed over structural integrity.
Exactly. But by concentrating the PRP and injecting it back into that site, you are overriding that default quick patch response. You're flooding the local receptors with growth factors.
Like a much higher dose than normal.
Yeah, 5 to 10 times higher than what naturally circulates in the blood. That massive concentration changes the chemical signaling. It tells the body to move past the scarring phase and actually regenerate healthy, elastic connective tissue.
Which brings us directly to how this applies to the most acute physical traumas of childbirth, perineal tears and episiotomies.
Yes, the stack actually includes a controlled clinical trial by Angeles and colleagues that tested this exact application. They followed 56 women who had sustained perineal wounds during vaginal delivery.
And how did they measure if the PRP was actually working?
They used a comprehensive clinical wound scale called the REDS scale. It tracks redness, edema, ecchymosis, discharge, and approximation.
Oh, so basically they systematically tracked the swelling, the bruising, and how cleanly the tissue edges were knitting back together, not just asking, hey, how do you feel?
Exactly, it was very objective. And the trial found that 92.9% of the women in the PRP group achieved a status of moderately healed. That vastly outperformed the control group.
Wow, almost 93%. So the PRP actively accelerated the whole timeline of tissue repair.
It did. But the regenerative potential extends far beyond those immediate weeks following delivery. There is a dramatic case report published in the Clinical and Experimental Obstetrics and Gynecology Journal.
Oh, right, the one about the 31-year-old woman.
Yes, she was suffering from debilitating pain during urination, basic sitting, and intercourse. And she had been dealing with this pain for 10 years following a deep episiotomy.
A decade of severe localized pain. That is just awful to think about.
Truly. But her treatment protocol involved 3 targeted PRP injections directly into the vaginal wall. They were spaced 3 weeks apart.
And what happened?
Following the treatment, she experienced a complete remission of pain. The exams confirmed significant neovascularization, which means dense new blood flow, plus a physical flattening of that decade-old scar tissue.
That is incredible. A 10-year remission completely challenges the assumption that old scar tissue is permanently dead tissue.
What's fascinating here is that PRP isn't just masking pain like a narcotic. It is actively remodeling the scar tissue and normalizing the pigmentation.
But, if a woman is suffering from a decade-old scar, does the tissue ever just age out of being able to be regenerated by PRP?
Well, older fibrotic scars are definitely tougher, but the cellular receptors for growth factors don't just disappear. The underlying fibroblasts are still there. They're just dormant.
Fibroblasts being the cells that make collagen, right?
Yes. When you introduce that highly concentrated dose of PDGF and VEGF, you are essentially waking up those dormant cellular processes. It stimulates them to replace the rigid scar with flexible tissue.
That is such a hopeful finding for anyone listening who assumed their postpartum pain was just a permanent fixture. But, healing external scars is one thing. Childbirth also inflicts heavy damage on internal structures.
Absolutely, leading to widespread issues like stress urinary incontinence, or SUI. That's the classic symptom of leaking urine when you cough, sneeze, or jump.
Right. So we need to look at what PRP can do internally and, crucially, what it cannot do, because the marketing can be a bit misleading.
Very true. Structurally, the O-Shot targets the periurethral area, which is the tissue directly surrounding the urethra. The goal is to stimulate collagen to strengthen the tissues supporting the bladder.
And the pilot studies in our stack are pretty encouraging on this front, aren't they?
They are. They demonstrate a 40 to 60% reduction in leakage episodes, plus a 70% overall improvement in SUI symptoms compared to standard midurethral sling procedures.
Which is a big deal because those sling procedures are invasive surgeries involving synthetic mesh.
Exactly. For mild to moderate stress incontinence driven by tissue laxity, PRP offers a non-surgical alternative.
But we have to look at the other side. There is a randomized controlled trial by Mogny and colleagues regarding pelvic floor dysfunction. They studied 58 women recovering from levator ani muscle trauma from childbirth.
Yes, and out of those 58 women, there was no significant difference between the PRP group and the placebo group, neither in actual muscle strength nor the levator hiatal area.
Here's where it gets really interesting, because you might read that and think, oh, the PRP failed. But that assumes PRP is a universal fix-all.
Which it isn't. And that's a vital distinction. PRP stimulates collagen and tissue elasticity, but it does not build muscle mass. It is not a replacement for pelvic floor physical therapy.
Let's use an analogy here. Think of the pelvic floor as a suspension bridge. The O-Shot can repair the frayed ropes, like the connective tissue and the collagen, but it can't bulk up the concrete killers, which are the actual muscles themselves.
That is spot on. Rebuilding the structural integrity creates a better environment for the muscle, but you cannot inject PRP into a damaged muscle and expect it to magically contract with more force.
Right, you still have to do the physical therapy, the Kegels, to rebuild that muscle mass.
The clinical reality is that PRP acts as an adjunct to physical therapy, not a replacement for it. Rebuilding the surrounding tissue is great, but muscular strength strictly requires mechanical load and resistance.
Okay, so with the mechanical structure addressed, we need to transition to sensory function. Because postpartum recovery isn't just about stopping pain or leaks, it's about reclaiming a healthy, satisfying, intimate life.
And historically, this is the most neglected aspect of postnatal care. Following childbirth, especially during lactation, women undergo profound hormonal shifts.
Yeah, a dramatic drop in estrogen levels. Right?
Exactly. And this causes vaginal dryness, atrophy, and dyspareunia, which is painful sex. The tissue literally thins out.
The sources detail how the O-Shot procedure targets this directly. It focuses on the lower one-third of the anterior vaginal wall, which is often associated with the G-spot, and also the clitoral complex.
Yes, and the outcomes from the scoping reviews are striking. The creation of new blood vessels naturally increases baseline mucosal lubrication.
So it tackles the dryness head-on.
It does. Furthermore, the growth factors actively support nerve regeneration. As those damaged microscopic nerve endings repair, patients report enhanced sensitivity.
The data mentions stronger orgasms and a sharp reduction in pain, too. And the timeline for this is actually pretty efficient.
Very efficient. The procedure takes about 30 to 45 minutes in office, and they use a highly potent topical numbing cream, so it's very well tolerated.
Right, and results can start emerging in just a few weeks, typically lasting anywhere from 12 to 18 months.
That's the general consensus in the clinical protocols, yes.
I want to pause here and speak directly to you, the listener. If you have gone through childbirth, there is a very high probability that someone told you that post-birth pain is just a new normal.
Which is incredibly frustrating to hear from a medical professional.
Yeah, that it's just something you have to live with, but this data actively and aggressively challenges that exact narrative.
It represents a fundamental paradigm shift in women's health. We are moving away from a traditional mindset of merely managing postpartum decline and moving toward actively rehabilitating the tissue.
Now, if all of this sounds great to you, we still need to ground this in the practical, regulatory, and safety realities before you go seeking out the treatment. Let's talk about the FDA status.
This is highly nuanced. To be clear, there is no FDA-approved O-Shot procedure. The FDA regulates medical devices, not specific procedural protocols created by doctors.
What they do regulate are the physical centrifuge kits used to isolate the plasma.
Yes, those kits are FDA-cleared as Class II medical devices. But injecting the PRP into the vagina is considered an off-label clinical use.
Which sounds scary to a lot of people.
If we connect this to the bigger picture, off-label use is incredibly common in medicine. Countless pediatric and cardiovascular treatments are off-label. The critical thing is ensuring your provider uses a sterile, closed, FDA-cleared kit.
Right, rather than unregulated test tubes that carry massive contamination risks. But when processed correctly, the safety profile is exceptionally strong. Because it's autologous, meaning from your own body, there's virtually zero risk of allergic reaction or tissue rejection.
Exactly. And unlike energy-based treatments like vaginal lasers or radiofrequency, which carry FDA warnings for potential vaginal burns, PRP is biological and room temperature.
But it's not for everyone. There are strict contraindications. You cannot undergo this treatment if you are currently pregnant or have an active pelvic infection.
Or if you have underlying platelet disorders. Patients also must stop NSAIDs like ibuprofen 2 weeks prior.
Because the PRP relies on a localized inflammatory response, right?
Yes, if you suppress that initial inflammation with ibuprofen, you neutralize the treatment. Also, it is strongly contraindicated for women who are actively breastfeeding.
I have to ask about that. If you can't get it while breastfeeding, which is exactly when a lot of postpartum dryness occurs, isn't that a frustrating catch-22 for new mothers?
It is undeniably frustrating. But the hormonal fluctuations of lactation, specifically the suppression of estrogen, significantly alter the local tissue's ability to respond to growth factors.
Ah, so the biological environment is actively resisting regeneration at that point.
Right. Clinicians advise waiting until breastfeeding has ceased and hormones have stabilized so the patient's investment isn't wasted.
And speaking of investment, we have to look at the cost reality. It is almost always an out-of-pocket expense, typically ranging from $1,200 to $1,800 in the US.
Or upwards of 150 pounds or more per session in the UK. An optimal result often require a series of treatments, spaced several weeks apart.
So, what does this all mean when we stack it all up? Based on the clinical guidelines, trials, and reviews, the O-Shot offers a scientifically backed autologous pathway to heal perineal scars.
Yes, and to dramatically improve connective tissue-based incontinence and restore sensory and sexual function after childbirth.
Provided you understand it won't fix muscle weakness, and you navigate the timing around breastfeeding. The ultimate takeaway for you is this. You don't have to accept postpartum discomfort as a permanent baseline.
Absolutely. But you should always consult a qualified medical professional about your specific candidacy and verify their equipment.
As we wrap up today's deep dive, I want to leave you with a final thought to mull over. We started by talking about a woman who suffered from a painful episiotomy scar for 10 years. We've just spent all this time exploring how a tiny vial of her own spun blood was able to regenerate nerve endings and literally erase a decade of rigid scar tissue from the inside out. It makes you wonder, if our own blood actively holds this much targeted, breathtaking regenerative power just waiting to be unlocked by the simple physics of a centrifuge, what other dormant, built-in healing mechanisms are hiding inside our cells right now, just waiting for medical science to discover the right key?